Nipah virus is a rare but deadly zoonotic virus that periodically sparks outbreaks in parts of Asia. Case fatality rates reported in past outbreaks range from roughly 40 to 75%, depending on location and care. That mortality makes Nipah one of the most severe emerging viruses we monitor, but severity alone does not equal pandemic potential. This report examines virology, transmission, outbreak history, diagnostic limits, and public health readiness to answer a critical question. We draw on public health agencies, peer-reviewed studies, and clinical reports. Stay with us for a clear, measured assessment of whether Nipah could become a global pandemic and what actions matter now. Nipah virus is a paramyxovirus first identified in 1998 during an outbreak in Malaysia linked to pig farms. Reservoir hosts are fruit bats, commonly called flying foxes, which shed virus in saliva, urine, and possibly on fruit. In humans, Nipah can cause severe encephalitis, respiratory illness, and rapid clinical deterioration in many cases. Symptoms often begin with fever and headache, progressing in serious cases to confusion, seizures, and coma within days. Laboratory studies show Nipah can infect multiple cell types and crosses the blood-brain barrier, explaining the encephalitic presentation. While deadly, Nipah remains a pathogen with specific ecological drivers and transmission patterns we can study and interrupt. Major outbreaks occurred in Malaysia in 1998 and in Bangladesh and India repeatedly since 2001, often seasonal and localized. Transmission pathways include direct bat to human exposure, contaminated food like date palm sap, and amplification via domestic animals. Human-to-human transmission has been documented, particularly in family and healthcare settings in Bangladesh and India. However, transmission efficiency appears lower than highly pandemic respiratory viruses. Spread typically requires close contact or droplets. Outbreaks have remained geographically limited when rapid detection and public health measures were implemented. Risk factors include close contact with sick patients, exposure to contaminated food, and ecological changes that increase bat-human contact. Diagnosing Nipah requires PCR testing of respiratory or cerebrospinal samples performed in high-containment laboratories. Access to advanced diagnostics can be limited in outbreak regions, delaying recognition and control efforts. Treatment is primarily supportive care. There are experimental antivirals and vaccine candidates, but no widely licensed vaccine yet. Preparedness relies on rapid case detection, isolation, strict infection control in hospitals, and community engagement to limit spread. International agencies, such as WHO and CDC, provide guidance and surge support when national systems request assistance. Investments in laboratory capacity, surveillance, and trained field teams have repeatedly limited Nipah outbreaks to local clusters. So, is Nipah the next pandemic? Current evidence shows high lethality, but limited transmission efficiency compared with established pandemic viruses. The primary drivers that would make a pandemic, efficient airborne spread and global seeding, are not currently characteristic of Nipah. That said, viruses evolve. Vigilant surveillance, rapid response, and vaccine development remain essential to reduce future risk. Practical prevention includes avoiding consumption of raw date palm sap, limiting bat exposure near homes, and strict hospital infection control. If you are in a region with cases, seek medical care early, avoid close contact with the sick, and follow public health guidance. For further information, consult WHO, CDC, peer-reviewed journals, and clinical summaries.